patients, 6 by Starzl in Colorado and 1 in France. All were unsuccessful. The longest survivor was about 28 days, so none of the recipients survived long term. When there was a self-imposed moratorium on liver transplants while they worked to figure out what had gone wrong with these 7 patients. And 4 years later, they figured that maybe now they could do it successfully. The first successful transplants were done in 1967. But until the 1980s, it was a fairly desperate operation with success rates of under 40%. But in 1981, cyclosporin became available and immunosuppression became safer. The success rates went up to the 80% range, and liver transplantation became the standard of care for liver failure. Then in the 1990s, once tacrolimus was introduced, the survival rates went up into the 90% range. And now it was basically standard of care. More and more centers began doing liver transplants. And the problem now became that patients were getting listed for liver transplants, but there were not enough organs from deceased donors to do the transplants. And there were still not that many liver transplant centers. So most patients who needed a liver transplant were not in circumstances where they would be offered it. So even now, I mean, if you look at figures in the US from last year, 2019, there were 13,305 patients waiting for a liver transplant. And the number of liver transplants done was 8,243. 1,194 patients died on the waiting list, 1,186. So a total of about 20% of patients either became too sick and were taken off the waiting list, or they died on the waiting list. And the patients who were taken off because they became too sick also die. I mean, typically about 80 to 90% of them die within about 6 to 8 weeks. Now, a living donor transplant would save this category of patients whom we are presently losing on the wait list. And the number of living donor transplants is not limited by the supply of organs from deceased donors. So if the US ever gets control of the opioid epidemic and the gun violence epidemic, then the number of donors is going to go drastically down anyway. So increasing deceased donors is not really likely to happen. So if you look at what was happening in the 1980s, I remember during my residency, a liver resection used to be a very desperate operation. And the quoted mortality for a major liver resection, a right hepatectomy, was about 50%. And the change actually came from transplant centers who became more and more used to operating on the liver. And one of the early papers was actually from Starzl's group in Pittsburgh. And they were presenting their data on liver resections. And this is from 1964 to 1988, so a period of time when there were very few centers doing liver resections regularly. 473 liver resections, and the overall mortality was 3.4%, which was much better than any other center had reported. Even with massive resections like trisegmentectomies, the mortality was only 5.5%. And when you look at left lateral segmentectomies, it was less than 0.8%. And the mortality in patients without cirrhosis, even with major resections, was only about 2%. So these guys had demonstrated that liver resections can be done safely. And so more and more centers began thinking about using part of a liver as for transplant, to do a liver resection on a normal person and use part of the liver for transplant, since there was such a shortage of organs from brain dead donors. And the first attempt to do living donor transplants actually happened in Brazil in 1989. And they reported 2 pediatric living donor liver transplants. Both these were ultimately not successful. At the time when they reported these 2 cases, one of the patients was alive, but that patient did die soon after. So these were not successful, but they did establish that the operation surgically could be done. And the donors did fine in both cases. The first successful living donor liver transplant was reported by Russell Strong from Brisbane in Australia. And this was a pediatric recipient. The mother donated to the child. And they described an operation very similar to the way we would do it today. So the left lateral segment was resected for transplant. And the left hepatic vein was directly anastomosed to the vena cava. The hepatic artery was directly anastomosed. The portal vein was directly anastomosed. The bile duct was reconstructed with a Roux loop. So it was very similar to the way we would do a pediatric living donor liver transplant today. And it was successful, and that child is now an adult, and I believe he has himself become a healthcare professional. I believe he's a physiotherapist. So Strong demonstrated that you can take part of a liver from an adult and use it to replace the liver of a small child. And the first report of doing this in an adult came from Japan. And this was Niigata University School of Medicine. So the recipient was a 53-year-old lady with primary biliary cirrhosis, very sick with a bilirubin of 20, ascites, grade 3 hepatic encephalopathy. The donor was her 25-year-old son, and his left lobe was used for transplant. And his left lobe volume was 434 ml, which was estimated to be almost 50% of her standard liver volume. This case also illustrated how quickly the liver regenerates. So the graft grew to 1141 cc, or basically full size, in 2 weeks after surgery. So these guys demonstrated that you can do an adult to adult living donor liver transplant. A lot of the early work in living donor liver transplantation was done at the University of Chicago. And at one point, they had done about 50% of the living donor liver transplants in the US. They published their data on the first 104 living donor liver transplants at their center. And they divided their experience into 3 phases. So in the first phase, that is 1989 to 1994, they had a rather complex way of reconstructing the graft. So the hepatic vein was anastomosed to the recipient right hepatic vein. These were pediatric transplants, so we're talking about left lobes and left lateral segments. And they used vascular conduits to reconstruct the portal vein as well as the hepatic artery. So they had a lot of complications in this initial set of patients. And they began to simplify the operation. And in the next 2 years, they would directly anastomose the hepatic vein to the left side of the IVC. They stopped using portal vein conduits. Then in the third phase, they stopped using arterial conduits and they started doing the arterial reconstruction under the microscope. And they started using anticoagulation. And interestingly, I mean, in that third phase, they basically ended up at what Russell Strong described in his first operation. So, and they said that as their technique matured, the outcomes improved. So with the most current technique, they had better than 90% survival for their patients. So if you do a lot of living donor liver transplants, you get better at it and the patients do better. The first report of using the right side of the liver for living donor transplant came again from Japan, and this is from Kyoto University. And the people in this group went on to establish many of the other living donor transplant programs there. So this was not actually planned to be a right lobe donation. They went into surgery planning to take the left lobe of the patient. They thought there was a single artery on the left side. And what they found during surgery was that the left side had 3 small arteries. So it would have been prohibitively difficult to reconstruct these 3 tiny arteries in the recipient. So they decided to take the right lobe of the donor instead. And that was successful, and that was the first reported right lobe living donor transplant. By now, although living donor liver transplants were being done by more and more centers, it was becoming evident that there are limits on what you can do with this. And this is the group from UCSF, and they were looking at the size of the liver, looking at how small a liver is enough to sustain the recipient. So this was over a period of 4 years, 25 living donor liver transplants. Most of them were pediatric, but 2 were adult. All the grafts were left lobe or left lateral segments. They had graft weights for 21 of the 25 transplants. In 12 of them, the grafts were larger than the recipient's expected liver weight, so small size was not an issue. But in 5 cases, the graft was smaller than 50% of the expected liver weight of the recipient. And 4 out of these 5 became encephalopathic in the first week. And 2 of the 5 lost their grafts because of poor function. 1 was retransplanted successfully, and 1 died of liver failure. And they described the changes that happen when the liver is too small. So early on, you get this ballooning degeneration in the liver. Later on, you begin to see some cholestasis, but also some regenerative changes. And by about 6 weeks after transplant, the liver is back to normal. So if you can keep the patient alive, the liver does recover. But during that period of liver dysfunction, there is a risk of liver failure. So if you're going to do living donor liver transplants, the graft has to be big enough for the recipient. Which brings us back to using the right side, because the right side of the liver is the larger side of the liver. It's typically somewhere between 55 to 70% of the liver. So we would be able to do a lot more living donor liver transplants if we can use the right side of the liver than if we use the rest, the left side. And the first series where they systematically used the right lobe for transplant came from the Hong Kong group, Queen Mary Hospital in Hong Kong. And they actually used what they called extended right lobe. So these were 7 patients who were very severely ill. All 7 were in the ICU. All had moderate to severe encephalopathy. 2 of them had intracranial pressure monitors because of high-grade encephalopathy. 3 were on ventilators. 5 of the 7 were on renal failure, and 4 of them were on CVVHD. So when they offered living donor liver transplants, they were able to work up the donors very quickly. So time from listing to consent was 36 hours, and time from consent to LDLT was 15 hours. And they took what they called the extended right lobe. So their plane of transection was to the left of the middle hepatic vein. So it was the right lobe with the middle hepatic vein. And the donors had what we would now consider a fairly long hospital stay, but they have a fairly relaxed admission and discharge policies. Some of the donors basically decided to stay admitted so that they could look after the recipient. One donor had a bile duct stricture which required surgery. One donor had an incisional hernia, but generally they all recovered and got back to a normal life. The recipient operation took a median of 16 hours. So it was a very complex operation for that time. The graft to recipient weight ratio, which nowadays we consider a ratio of 0.8% or more to be adequate, was 1.1%. So by taking extended right lobe grafts, they made sure they were providing enough liver volume. And one of the recipients died of fungal sepsis, but all the other recovered from transplant. So these two papers established that the size of the graft is important in living donor liver transplant. And one of the early large experiences with right lobe living donor liver transplant was actually from VCU, which is where I'm working now. Amadeo Marcos was one of the pioneers of adult to adult living donor liver transplant. And this was their early experience here in Richmond. So this was over a period of 2 years. They did 25 adult to adult living donor liver transplants, which at that time accounted for 40% of all the liver transplants. Operating time was down to 8.4 hours. The hospital stay for the donors was less than 6 days. Again, they were taking good size graft. So the graft to recipient weight ratio was more than 1%. The recipient's hospital stay was less than 2 weeks. The most important problem turned out to be biliary complications. So 1/4 of the patients had biliary complications, and 5 out of 6 needed reoperation to fix the biliary problem. But the patient and graft survival was excellent at 88%. So it was, for that time period, it was as good as with good deceased donor livers. And they updated their series when they got to 40 adult to adult transplants. And after the first 22 cases, they started doing living donor transplants only in the less sick patients. So anyone who had a MELD score of more than 25 would be not offered living donor transplants. They would be listed for a deceased donor transplant. And this was a simpler operation than the Hong Kong group had described. So the middle hepatic vein was not taken with the graft. The ducts were isolated when about 2/3 of the parenchymal transection was done, and they were divided before completing the separation of the liver into right and left side. The problem with this is that if something goes wrong with the recipient operation at this point, then you've already done something irreversible in the donor. So you're left with what's known as an orphan graft. So those patients, the donors used to give consent that if the recipient operation goes badly and the recipient is not in a condition where he can be transplanted, then this right lobe graft can be used for someone else on the wait list. So 40 right lobe living donor liver transplants. During this time, there were 39 cadaveric transplants. And there were 5 mortalities in the living donor group. 4 of the 5 were in patients who were status 2A, that is the sicker patients in the earlier part of the series. That's why they stopped offering living donor transplant for the sicker patients. So adult to adult living donor transplant still continuing to look like a good idea. The question was, of course, whether you can do it in the sicker patients. And again, the data that you can do it came from Hong Kong. And they looked at what happened to their patients who were in the ICU with acute or chronic liver failure and listed as high urgency for liver transplant. So 49 patients, 25 of them had no living donors, and 23 of the 25 died on the waiting list. Only 2 of them got a deceased donor liver transplant on time. So the situation was somewhat like we have in India, where the availability of donors is low. So the very sick patients tend to die before they can get transplanted. 24 of the patients had living donors. Two of them still got deceased donor liver transplants because the deceased donor became available while the living donor was being worked up. 9 of them, there were contraindications to going ahead with living donor transplant. One of them again got a deceased donor liver transplant, but the other 8 died on the wait list. So 13 ended up having living donor transplants and 11 of them survived. So if you compare the survival, 11 out of 13 of those who had living donors and 2 out of 25 among those who did not have living donors. And in fact, I was somewhat surprised to find that they did a living donor liver transplant for fulminant hepatic failure here, where this was an adult, a 28-year-old male with fulminant hepatic failure due to hepatitis B. And he had 3 siblings who volunteered to donate to him. All 3 were simultaneously evaluated. Evaluation was completed in less than 24 hours, and the living donor liver transplant was completed within 36 hours of admission. The donor recovered uneventfully, discharged on day 4, and the recipient recovered uneventfully and was discharged on day 14. The first offer of a cadaveric liver transplant came 60 hours after the living donor transplant was completed. So it looks like they didn't take him off the list immediately. He remained on the UNOS list, and the first offer came quite a bit later. So you can do living donor liver transplant even in the sickest patients. One of the interesting questions which comes up, and in fact, I had given a 1-hour talk just on the middle hepatic vein. So one of the interesting questions that comes up is what to do with the middle hepatic vein when you do a living donor liver transplant. If you look at the anatomy of the liver, the inflow structures divide into right and left. So you have a left portal vein and a right portal vein, left hepatic artery, right hepatic artery. So you can separate the inflow on the right side and the left side. The hepatic veins, on the other hand, there are 3 of them. So there's the right hepatic vein, there's the left hepatic vein, but there's a middle hepatic vein which has tributaries from both sides. So when you're splitting the liver into a right side and a left side, the question comes up what to do with this vein. And the first suggestion that this was a problem actually came from the Asan Medical Center group in Seoul in Korea. They're one of the most experienced living donor liver transplant centers in the world. And what they described was, so this was in the early days of living donor liver transplantations, 1994 to 1998. And they had a series of nearly 50 living donor liver transplants, out of which 5 were right lobes, and they were taken without the middle hepatic vein. The middle hepatic vein was left behind in the donor, and the donor remnant volumes ranged from 29 to 38%. So the donors had no problem. But what happened in the recipients was 2 of the recipients had this marked congestion of the anterior sector of the liver. This is the part of the liver where the venous drainage would have gone into the middle hepatic vein. So you had congestion there, which became more well-defined after some time. And one of these recipients basically died of liver failure because the volume of functioning liver was insufficient, even though the actual liver volume was enough. In the other one, the congested volume was less, and the patient eventually recovered. But what they realized was that the venous drainage of the anterior sector of the right lobe is important. So this is a problem which you can't ignore. If the liver is partly congested, then it's not going to function as well as a full liver. So the Hong Kong group had already said that you can take the middle vein with the graft, but there have been concerns that might impair the recovery of the donor. So our preference also is, as far as possible, to make sure that we have good drainage of that part of the liver. And we described what we do in this paper in 2011. So this is what happens even if you reconstruct the tributaries of the middle hepatic vein. So in this case, a large segment 8 tributary has been reconstructed. You still get a fair bit of congestion. So a lot of segment 5 is still congested in this case after implantation. So this might still work out if you have enough liver volume, but if the liver volume is marginal, then you really can't have a graft which is as congested as this one is. So we basically tailor what we do with the middle hepatic vein depending on the anatomy in the donor. And this is basically a liver which is designed to be split. You have practically a double middle hepatic vein. So the segment 4 is draining right up near the top of the middle hepatic vein, between the middle and the left hepatic vein. So you can take the middle hepatic vein with the right lobe and not worry about congestion in the donor. This is ideal anatomy for right lobe with middle vein. This is also good anatomy because most of the segment 4 drainage is going into the left hepatic vein. So you can take the middle vein with the right lobe. This is more problematic, and this is in fact fairly common, where the middle hepatic vein is getting large tributaries from both sides. And here we have to tailor the part of the middle vein we're taking with the graft and the part we're leaving behind, and plan the operation accordingly. So depending on what part of the middle vein we're taking, there are different ways of reconstructing the outflow. But the key is to make sure that you think about the venous drainage of the graft and reconstruct it so that you don't have any congested portions of the liver. So in India, of course, we used to use the recipient's portal vein to make these extension grafts because we didn't have cadaver veins. So over here now in the US, I have the luxury of iliac veins from deceased donors, but this is what we used to do when we were doing this in India. So you have this graft with multiple veins which need to be reconstructed. There's a middle hepatic vein, there's a separate segment 8 vein, there's a right hepatic vein, there are 2 accessory right hepatic veins, and all of these have to be reconstructed to make sure that the graft works properly. And this is a portal vein being used to reconstruct segment 8 and middle hepatic vein. And this is part of a donor operation where the entire middle hepatic vein has been taken with the right lobe. And you're going to get basically a perfect right lobe graft in this. So with a perfect graft, you can get away with a small liver, but there are limits even to that. And one of the ways of getting around those limits again came from Korea, the Asan Medical Center again, where they described using dual lobe grafts. So the first case they described was this one. So the recipient had end-stage liver disease because of hepatitis B. And the prospective donors were a brother and a daughter. The problem was both of them had oddly shaped livers. So their left lobes were less than 30% of the liver volume. So it would be hazardous to take out the right lobes. So they decided to take the left lobe of both the donors and put the 2 left lobes in. Now the problem with this is that the left lobe that you're putting on the right side has to be flipped around. So the bile duct is the most posterior structure. So you actually have to reconstruct the bile duct before you can reconstruct the vessels, which results in a much more complicated operation. But they described how it can be done. And this is a CT scan early after transplant, where you can see the two left lobes. This is about 2 weeks after transplant, where the left lobes are growing in size. And this one is 2 months after transplant. You can see that the two left lobes have changed not only in size but also shape, so that now they practically look like a normal shaped full liver. So if the donor's liver is too small for the recipient, you can think of two donors. Which brings us to the donor risk. So in living donor liver transplant, the main concern for everyone is that nothing should happen to the donor. The donor is a normal, healthy person, and the most tragic thing that can happen is a donor dying. And there are quite a few papers which have tried to estimate the risk of death and complications for the donors. But the best one I found was this one. This is from the Johns Hopkins group. And they're looking at estimates of early death, acute liver failure, and long-term mortality among liver donors. This was published in 2012. And so the advantage in the US is that there is documentation of all live liver donors. So they're looking at all living donor liver transplants over a period of about 17 years. So the early post-op events were reported to OPT and by the centers, but the centers were not required to follow the donors beyond 2 years. So for the later events, what they did was they went to the Social Security death master file. So you have the Social Security number of the donors on record. And if anyone dies, the death is recorded in the Social Security documentation. They compared the liver donors with kidney donors, and they also compared them with people who had not had surgery. So they used participants in a health and nutrition survey. And in this survey, they ruled out people who had comorbidities that would have kept them from donating. So they're trying to get comparable patients from this survey. And they followed all these people up. So 4,111 liver donors. 2/3 of them had donated the right lobe. The others were left lateral and left lobe donors. In the early part of the experience, this was predominantly pediatric transplants. In the later part of the experience, it trended towards adult to adult and more of right lobes. So if we look at deaths within 90 days of transplant, there were 7, which gives us a rate of 1.7 per 1,000 or 0.17%. For kidney donors, it was 0.5 per 1,000. So the risk of death for a liver donor is about 3 times that of a kidney donor. It made no difference whether it was to an adult or a pediatric recipient, and it made no difference whether it was the left lateral segment or the left lobe or the right lobe which was donated. They all had similar risks. So it seems to be not the liver volume, but other things which lead to mortality. The long-term mortality was 31, 1 per 1,000 person years. And this was the same as kidney donors, and this was the same as the matched normal population. So if you follow people over a period of 17 years, some of them are going to die of some disease, car accidents, murders, suicides, and so on and so forth. So the long-term mortality did not differ between liver donors, kidney donors, and people who never had surgery. And if we look at the cause of death for these donors, this is a left lateral segment donated, died on post-op day 2, anaphylactic reaction to a drug. Right lobe donor died of multi-organ failure. So this might have been potentially liver failure. Right lobe donor died day 3, infection. This was a donor in New York who actually died of gas gangrene of the stomach. This is left lateral segment donor, died 2 months after surgery of a drug overdose. Left lobe donor died almost more than 2 months after surgery, committed suicide. Right lobe donor, cardiovascular. This cardiovascular was actually intraoperative bleeding. Right lobe donor, respiratory arrest. Not sure what happened in this one, but might have been a pulmonary embolism. So the cause of death seems to be things which are common to any major surgery and not specifically liver donation. And as you can see, the long-term survival is the same between liver donors, kidney donors, and people who did not have surgery. So there was a worldwide survey, and it showed that the rate of donor complications is about 24%, and most of them are grade 1 or grade 2, things like needing an antibiotic or needing a blood transfusion. 0.04% rate of need for transplantation for the donor because of liver failure, and a 0.2% mortality rate. So when donors were asked whether they would donate again or not, 95% of them said that they would donate again. And that 5% who said they wouldn't were predominantly donors whose recipients had died, and they had feelings of guilt or responsibility for the recipient's death. Looking at how fast the liver grows after donation, this is something we looked at in Mumbai. We looked at donors who had had CT scans after donating for any reason. Typically, this was to see if they had an intra-abdominal fluid collection, so a rise in count, unusual pain, all these things would make us do a CT scan. And we plotted the size of the liver against the number of days after donation when the CT was done. And we found that the regeneration happens fairly quickly. It's the first 2 weeks when it grows the fastest. And by about 10 days after donation, a lot of them are already at about between 70 to 90% of their original size. And something interesting we noted was that in a couple of cases, they ended up with a regenerated liver, which was larger than what they started off with. Doesn't always happen, but we found that donors who had a small liver to begin with would sometimes overshoot. So this is a donor who donated the right lobe of their liver, and the left lobe grew and became more than 1 kilo at 3 weeks. So it became larger than the original liver was. And this is another one. Again, the right lobe was donated. The original liver size was 844 cc, and the left lobe grew to 943 cc 10 weeks after donation. So the key is we always worry about the donor, but it's not as bad as most people think when they think about living donor liver transplantation. Of course, cost is a consideration because you have 2 patients that you have to look after. And for most of the history of transplantation, cost has been a problem in living donor transplant. So one of the early papers to look at the cost comparison was from 2003. And they looked at 49 adult to adult right lobe living donors. 24 of them had more than 1 year follow-up. They were compared with 43 cadaveric recipients from the same period. And they didn't give the cost in dollars, they gave it as cost units. The cost in dollars is quite scary. But anyway, in terms of their arbitrary cost units, 90 days pre-transplant, the cost with living donors is higher because the cost of evaluation of the donor comes in during this period. The transplant admission, the cost was higher for living donor liver transplant. They had longer hospital stays. And I think a lot of this would have been related to biliary complications. Once they were discharged, the cost was less for the living donor transplants. But overall, the cost for a living donor transplant was about 20-25% more than for a deceased donor transplant. So this was the response from most US centers. It's expensive. So this was the experience from VCU. This was a paper published in 2005. And they were comparing 69 living donor liver transplants with 202 deceased donor liver transplants over a period of 6 years. So the living donors were about 1/4 of the transplants during this period. The living donor recipients had less rejection, almost half. They had more biliary complications, a little more than double. The waitlist mortality during this period was 21%. So obviously the waitlist mortality only applied to the deceased donor transplants. So of course, in terms of intention to treat, the living donor transplants did better. So the operative technique was similar to what was originally described in the first 40 transplants. And if we look at the cost for the deceased donor transplants was about $321,000, and for living donor transplants was about $374,000. So there was a $50,000 difference in cost between deceased donor and living donor transplants. And the survival was very similar over a follow-up of about 6 years. The graft survival was also very similar. If we compare this experience into 2 eras, comparing the first 23 with the next 46, there was a significant improvement in patient survival and graft survival. So there is a learning curve effect, and the more transplants you do, the better you get. But it's still more expensive, right? There's a $50,000 difference in expense. About this time, there was a very important paper which came out in the American Journal of Transplantation. And they were looking at how sick a recipient was before transplant and how much benefit they got from getting transplanted. So they're looking at almost 13,000 patients listed for liver transplant over a period of 3 years. And of course, not surprisingly, they found that patients who were transplanted had a 79% lower mortality risk over a period of 1 year. So hazard ratio of 0.21. So basically, a patient who was transplanted was not transplanted had 5 times the risk of dying over a period of 1 year than someone who was transplanted. And of course, the sicker the patient was, the more the benefit of transplant was. So a very sick patient, of course, is much more likely to die without transplant. What they found was that at MELD scores of less than 15, the risk of dying was actually more if they got transplanted than if they remained on the wait list. So at MELD of 6 to 11, the hazard ratio was 3.64. That means that the patient was almost 4 times more likely to die if transplanted than if they remained on the wait list. So this paper led to a change in organ allocation, and priority was given to patients who had a MELD score of more than 15. Patients with a MELD score of less than 15 were much less likely to get a transplant. This is different MELD scores, and this is their hazard ratio of having a transplant. You can see with MELD scores of less than 15, the hazard ratio is more than 1. So they're more likely to die if they have a transplant than if they don't. But this changed when they looked at living donor transplants. So this paper came out in 2011, and here they're comparing survival in living donor recipients with those who had deceased donor transplants according to MELD score. So the living donor patients came from their consortium, the A2ALL consortium, looking at living donor outcomes in a group of centers, median follow-up of 4.6 years. So the mortality rate of living donor recipients were compared to those who remained on the waiting list and those who got deceased donor transplants. And they were divided into those with a MELD score of less than 15 and those with a MELD score of more than 15. So 868 patients. About half of them had a MEL score of less than 15 when they entered the study. 712 were transplanted, 406 living donor transplants, 306 deceased donor transplants. 83 died without transplant, and 73 were alive and still on the wait list without transplant. And the living donor recipients had a 56% lower mortality. So the other patients had more than double the risk, about more than double the risk of dying than those who had a living donor. And in patients without HCC, the benefit was seen even in those who had a MELD of less than 15. So patients undergoing living donor liver transplants had a survival advantage over waitlisted patients across the whole entire spectrum of MEL score. So even those with a MEL score of 6 to 10 did better if they had a living donor transplant than if they continued to wait, which was very interesting. This was a overall report on outcomes of living donor liver transplants in the US. And some of the things they found was that there's a definite learning curve. It's a complex operation and it takes time to get good outcomes. So they felt that the learning curve was 15 to 20 transplants. But none of these centers had a very high volume. So they may not have seen the learning curve effect, which comes in at 50, 100, 200, 300 transplants. Graft survival was 81%, and living donor liver transplant was superior to deceased donor liver transplants. So in their entire series, there were only 12 centers performing more than 10 living donor liver transplants per year. To look at long-term survival, the patients who had living donor transplants had about a 6% advantage over those who had deceased donor transplants. The major problem was biliary complications. And that's always been considered the Achilles heel of living donor liver transplant. You can do everything else perfectly, but you can never be sure that you won't have a biliary complication in the recipient. So if we look at the A2ALL consortium, they've very systematically looked at their biliary complications. And 8 centers over a period of 8 years, median follow-up of nearly 5 years. So in their deceased donor transplants, they had a 25% biliary complication rate. It seems fairly high nowadays. And in the living donor liver transplants, it was nearly 40%. Problem is the average number of living donor liver transplants per center per year is only 5.5. So essentially not very high volume centers for living donors. So some of the high biliary complication rates might be to do with volume. So this is a paper looking at variation in biliary complication rates and its effect on the cost. So this is deceased donors. So they're looking at data from the UNOS database. And so transplant centers were assigned to quartiles based on how many biliary complications they have. And these were done separately for donation after brain death and for donation after cardiac death. So the highest quartile donation after brain death centers had almost 20% biliary complications. Lowest quartile was about 6%. Similarly, for donation after cardiac death, it was about 20% and 8%. So what it showed was that centers with higher biliary complications were the more cautious centers. So they were using low-risk donors. They were doing less splits. They were doing less imports. So these were probably the relatively low-volume centers. And the centers with the highest biliary complications also had higher mortality and graft losses. So the centers which had more biliary complications spent nearly $23,000 more per transplant than the centers which had low biliary complications. The outcomes improve with experience. And in 2010, we had described our experience with biliary reconstruction. So the basic idea is that the blood supply of the bile duct runs in the sheath around it, the Glisonian sheath around it. So we shouldn't dissect the bile ducts. We should take the entire Glisonian sheath as a single structure. So when we encircle the bile duct, we don't go for the bile duct itself, but we encircle the entire Glisonian sheath. So you can see this is the right hepatic artery going into the liver, and it typically gives off a small branch which goes into the Glisonian sheath. It supplies the bile duct. And this is what it looks like when you've got the right side Glisonian sheath encircled. So we don't divide the bile duct until we are ready to take out the liver. So no irreversible steps are performed in the donor operation until we know the recipient liver is out and it's ready for implantation. So this is I can get this video working. Sorry, doesn't seem to be working. Which part of my screen can you say?
But it's actually the overview. So now you
Right.
are the main complete
Okay,
screen.
let me fix this again.
Yeah.
Oh God, my PowerPoint thing is restarting. Okay, let me get to that slide again. Can you see it now?
Yeah, it's the first slide now. So
Yeah, I will find that one. My PowerPoint seems to have restarted for some reason when I tried to play the video. Right, so I will not try to play the video this time. Oh, okay. Looks like it's going to show it. So the idea is to have a good blood supply in the bile duct. What you see here is that the entire Glisonian sheath is going to be divided sharply with a scissor. And you should see this arterial spurting from both sides, which basically indicates that the blood supply on both sides is good. So you see these crossing streams of blood showing that the bile duct has a good blood supply. And this is what it looks like. So you see a Glisonian sheath surrounding the bile ducts, and you basically treat the entire thing as a single structure rather than trying to separate the two bile ducts and reconstructing them separately. So we compared 244 cases done this way with the previous 158 done before we started doing it this way. So with the conventional group, the biliary complication rate was 15.8%, and it dropped to 5.3%. What was even more important was that the proportion of biliary complications needing surgical correction went down from 44% to 7.7%. One of the most experienced centers in living donor liver transplants is the Asan Medical Center. SG Lee is the head of the program over there. They've done more than 5,000 living donor liver transplants with no donor mortalities. And the survival rate in the recipients is 97%, which is remarkably impressive. And about 25% of their transplants are now ABO incompatible across blood groups. And even in the ABO incompatible group, they have excellent graft survival rates. In fact, there's no difference in their series between compatible and incompatible. And they published the effect of center volume. They compared all the centers in Korea, and this is the volume, number of transplants per year. They had to put a break in the graph because one center was so far beyond all the others. So it's not according to scale. And on the y-axis, we have the mortality. So you can see the high volume centers, those are doing more than 50 transplants a year, have excellent outcomes, whereas those who are doing occasional transplants have very dismal outcomes. One of the recent experiences with living donor transplant, probably the largest experience in the West, comes from UPMC. This is something they published last year. And they compared outcomes of living donor and deceased donor transplants. They have a waitlist mortality of about 20 to 25%. The deceased donor patients have a long wait list. The disease progresses. The patients need to have a very high MELD score before they're transplanted. Some patients are never listed because you know they are sick, and before their MELD score gets to the point where they'll get a liver, they're going to die. So you don't want your waitlist mortality to go up, so you don't list them at all. So living donor transplant is the solution to all this. So this is their 10-year experience, 592 deceased donor transplants compared with 245 living donor transplants. And the 3-year survival was better. It was about 6% more with living donor liver transplant. The need for intraoperative blood transfusion was less with living donor liver transplants. The hospital stay was 2 days less with living donor liver transplants. The need for dialysis was much less with living donor liver transplants. And even the biliary complications were less in living donor liver transplants than in deceased donor transplants. And they found that in elderly patients, those who are more than 70 years old, living donor liver transplant was much better than 93% survival compared with about 80% with deceased donor transplant. And because everything is less, the hospital stay is less, the complications are less, the cost is also 30% less with living donor liver transplant. So once this paper came out in Annals of Surgery, a lot of transplant centers in the US have started thinking about starting living donor programs. So this is survival over a period of 36 months, comparing living donor and deceased donor. And the living donor patients do significantly better. This was our experience from Gangaram Hospital. This was the number of transplants per year. So the program really took off in 2005, 2006, and kept on growing after that. These are figures between 2001 to 2012. So 675 transplants, only 13 of them were deceased donor, all the others were living donor. Just under 10% were pediatric transplants. There were 9 combined liver, kidney, 2 dual lobes, 4 paired donor exchanges, 1 domino. The overall success rate was 92%, that is patient recovering and going home. In-hospital mortality was 8%. 2 donor mortalities in the early part of the experience. 1-year survival, 90%, 3-year survival, 86%. So generally what you find is that most experienced transplant centers will settle at this kind of success rate with living donor transplants. Is there a benefit to the donor? Obviously, there's no medical benefit to the donor, but there do seem to be benefits in terms of they're feeling good about what they did, their self-esteem. So this is Abhishek, donated right lobe of his liver to his father, and got into working out and bodybuilding after transplant, and this is him 6 months later. This is Rukaiya. She donated the right lobe of her liver to her mother. She runs the Mumbai half marathon every year. She goes skydiving. So they do things which they otherwise wouldn't have done because they feel so much better about themselves. So the donors are my favorite people. They're all awesome people who have the courage and the generosity to do this for someone else. So we restarted the Living Donor Program over here in VCU last year. We've done 18 living donor liver transplants since then. This included one domino, one ABO incompatible. We had 2 donors who donated after bariatric, not immediately after, but they had bariatric surgery in the past. We had 1 donor who donated liver after kidney. The kidney donation was a few years ago. Only 1 grade 3 complication, a donor who needed a percutaneous drainage of a fluid collection. And so far we have 100% graft and patient survival. The recipients, we had 1 recipient whose own portal vein was not usable, so we used a vascular venous conduit. The conduit thrombosed on the first post-op day and we had to do a thrombectomy, but the patient subsequently recovered. 1 recipient in whom we used a left lobe had small for size syndrome, but she recovered with conservative management. 3 biliary complications, 2 leaks and 1 stricture, all of them have been resolved. This was the first ABO incompatible living donor liver transplant. And it actually happened during the COVID surge. So the patient had massive bleeding into the spleen. So we had actually stopped doing living donor liver transplants for a while. But because she was at risk to re-bleed, we decided to go ahead with this ABO incompatible transplant. So the son donated to the mother. So our strategy here is to offer living donor liver transplants to patients who are relatively low MELD, but they're sicker than their MELD score would indicate. So these are patients with intractable ascites, recurrent encephalopathy, muscle wasting, fatigue. So these are things which make them sick but don't raise their MELD score. These are patients who would otherwise die on the wait list. We are thinking about doing this for patients with HCC beyond Milan, cholangiocarcinoma. We've started doing this for colorectal liver metastasis and neuroendocrine tumors. And thank you, and we will take any questions the audience might have.
Thank you, Vinay.
Wonderful lecture, Vinay, as usual. Now I'll throw this open for comments and questions. Ilango?
Yeah,
there you are.
So Vinay, as usual.
Volume, you should increase your volume, Ilango.
Let me change my...
Is it better now?
Yeah, much better.
Thanks for the wonderful lecture. I started listening to it and I think I speeded up so that I should not miss this discussion. So I'll start the question and answer session here. What was the technical aspect in living donor liver transplantation history which you feel was the watershed moment in the acceptance of liver transplantation? What tilted that balance?
I think probably using right lobes, because before that it was restricted to pediatric transplantation. And it was only when they started using right lobes that it became applicable for adults. After that, there have been various technical modifications which have incrementally improved the outcomes. But I think the key was when they decided that the right lobe can be used for adult-to-adult living donor liver transplant.
So we were very fond of your middle hepatic vein controversy lecture. So I was rooting that you might say that the controversy was the key shed one. I mean, there was a whole ILTS session dedicated on that middle vein controversy.
Right.
So good. And your paper, your group's paper, hylar plate glissonian sheath approach on for the biliary, it's still the ones which I really love the most. What do you think?
We just published our paper on the W technique for the arterial reconstruction. So it's published, well, it's been accepted in Annals of Transplantation. So it will be available as free full text soon.
Yeah, anyway, you have shared that technique with me. It's very
Yes.
impressive. I use it for so many other things as well now. So, what is the key step a young surgeon should follow in reducing the biliary complications? So, let's keep that hilar plate glycerol sheath approach away. And what would they do in a recipient hepatectomy? Most of the juniors, they start with the recipient hepatectomy. What do you think they should be doing to get the bile duct anastomosis right in ALDLT?
So what I like to do in the recipient hepatectomy is to leave the bile duct to the end, right? So I will dissect the arteries first, ligate them, mobilize them nicely, and I will leave the bile duct with a lot of tissue around it and not attempt to do anything with it at all. And mobilize the liver, get it ready to practically come out. Then when I'm ready to take the liver out, that's when I clamp the portal vein first. And I divide the bile duct high up. So I cut it well into the liver. If you do that after you've ligated the arteries and after you've clamped the portal vein, then you don't have to deal with the distal end of the bile duct, right? You don't have to deal with the back bleed. So you can cut well up into the liver. That way you get a sort of hammerhead of the bile duct. Its bifurcation into right, left, caudate, segment 4. So you often get 3 or 4 bile duct orifices in the recipient duct. And because you haven't done any dissection around the bile duct, you get a very good blood supply. So when you divide it, you'll see a nice spurt from the ends of it as arterial spurting and venous bleeding from the end of the bile duct, which illustrates that you've got good blood supply right up to the end. That gives you options when you're reconstructing it. So if the graft comes with 2 or 3 bile ducts, you can still join all the bile ducts on the recipient duct and get a sort of big plate kind of thing, which you can join to the whole hilar plate of the donor liver. So I think that helps. So leave the bile duct division right up to the end, divide it after clamping the portal vein, so you don't have to do anything with the liver side bile duct. And I think that helps to get a good duct-to-duct reconstruction.
Perfect. So that is the high hilar dissection technique.
Yes.
So yeah. Okay, Jashwant sir is here. Jashwant sir, would you? Jashwant sir, are you here? Prathapan. Okay. Any other questions? So would you also describe your W technique for arterial anastomosis? In a very brief, I think there are surgeons here.
It's very difficult to describe until you see. You have
see that once. Yeah,
you have to be frustrated at the conventional technique and then see it. Only then you realize how easy it makes it. It basically takes the skill out of the process. It makes it a very systematic thing which anyone can do, rather than something highly skilled part of the operation, which is only done by the most senior surgeon, which is what most living donor centers do, right? The head of the program basically keeps the arterial anastomosis for himself.
True.
But this makes it so
that you taught the technique to. You taught the technique to me at a very important phase in my life. So I still keep that. It's one of the first reference papers I keep once you share.
I'll email you the paper as well. It'll be available free text soon, but I'll send you the proof.
Thank you. Thank you. So I think a wonderful lecture as usual. If there are no questions, we are so glad to have you back in LGS talking on transplantation. We would like to hear more of your lectures often. You're very organized. It's wonderful to listen to your lectures when I'm driving, and I keep listening to the YouTube lectures. Thank you for being there for us and for all the youngsters. Thank you.
Thank you for
thank you, Vinay. Thanks again for spending a morning with us, and it's been lovely. And we wish you come back again, maybe in due course of time. Thank you. Thanks.
Thank you.